so that I can put them to the rest of the panelists. We can't answer individual medical questions. Please do speak to your healthcare team if you have any of those. And we will try and get to as many as we possibly can in the time, but we have already had quite a lot through have come through in advance, so do bear with us on that. Charlotte, do you want to give us an update on the government guidance?
Sure, no problem. So, although this says an update, I am largely going to repeat a lot of what we said last time, but I think that it's important to reiterate messages. So just to remind you what the general government guidance was back around the 20th of March, when they first announced the shielding policy to protect people from who may be at risk of severe side effects if they contracted the COVID-19 virus. So they specified two groups that are relevant to CML that should be shielding, and these are people with cancers of the blood or bone marrow, such as leukemia, so that clearly includes CML patients. And then there's also another section that spoke about particular cancer treatments that affect the immune system, such as protein kinase inhibitors and TKIs that you take for CML are included in this. So CML patients were clearly meant to be covered by this general government guidance at that time. And just to recap what we discussed, well, I say we, I wasn't there, but what the rest of the panelists discussed at the last webinar, Steve reiterated that all CML patients should be shielding under this policy. And I won't go into that in any more detail. We'll discuss that further today, whether that still applies. And at the time, certainly, there was little or no evidence of effect of coronavirus on CML patients in particular. And we encourage you to consider speaking to your haematology team if you had COVID-19 symptoms, as well as the usual COVID-19 processes such as 111. Since the last webinar, of course, there have been many news reports. I mean, COVID-19 has not been out of the news, but there have been some particularly significant news reports last week and slightly the week before as to whether the general lockdown related to coronavirus will continue. So the initial 12 weeks of shielding specifically ends on the 30th of June. And the announcements last week regarding the general public lockdown stated, and if you've read the 50-page strategy from the government, you will have seen this, that there is no change to shielding at this point. The June deadline is still in place. And we still aren't clear on what the next steps are in terms of shielding. So we'd encourage you to try not to speculate or make decisions too early at this point. And please reach out if you need support. There is still lots of support out there in terms of practical support. There is still those services around getting food delivered and things like that available. But also please reach out for emotional support to places like charities or your GP or things like that if you're struggling with the current situation. And I just wanted to very, very briefly go over what shielding means and some of the support. And you would have seen these slides if you joined us last time, but just to very briefly go over them again. So what does shielding actually mean? So this means don't leave the home, including for exercise. And the only exception is for medical appointments. And the advice for those living with those shielding was there is no need to shield. And there are some specifics listed on the screen of how to maintain this social distancing within the house. And what to do if you didn't have a letter regarding shielding. As you know, many people were sent letters specifically to advise them to shield. And the advice still remains the same about this. If you're in need of a letter and you didn't get one through the first wave or subsequent waves of letters that have gone out, please speak to your GP is the one who can issue the letter, but the haematologist also may be able to assist depending on local processes. So please let someone know if you need a letter. And also let us know if you need further support, because we can assist with that too. And then very briefly, just to go over treatment changes again, and I'm sure that Steve will be able to provide any more insight on this if it is relevant. But in terms of deciding whether to treat a patient at this time, there was never any sort of blanket advice from the government to stop delivering cancer treatments. And urgent cancer treatment was always a priority. And I guess I've put access perhaps more relevant here because CML treatment is largely conducted away from the hospital, which was sort of the main concern regarding cancer treatment at the beginning of the pandemic. But if you are having trouble accessing your usual treatments, please let us know. That's something we can assist with. We're not aware of any issues, I should say, but if you are having an issue on a personal level, please let us know. And I think the important thing to say as well is, if you are asked to attend an appointment, despite the fact you're shielding, please attend. Doctors are only asking patients to actually attend appointments if they are essential. And if you aren't sure as to what the processes are or whether you should be going or not, please speak to your haematology team and they'll be able to advise on local processes. So that's all I wanted to say. Just wanted to recap on last time and outline the current situation. So I'll pass over to Zach and to, unless you want to go straight to Steve.
Steve, did you have anything you wanted to specifically say at this point before we get into the questions?
There's three things I'd put on the table for everyone to think about, really, Zach. And I emphasised a couple of these things last time, and I shall do so again now. And the third thing is more nuanced. So the first thing to say is, I'm not an expert on COVID-19, and very few people on the planet are experts, are genuine experts who really know the answers to a lot of the questions that we all have. I guess I know a little bit about CML. So I think the nature of this call, this webinar, is going to be more of a discussion about, balances of risks, what the experience might be in CML patients, and there's little information there. But, that's the first thing I'd say. There are very few people, if any, who
I think we've lost Steve for a second. Let's just see if his.
I was just wondering if it was me.
Pronouncement on the telly.
We lost you for a second there, Steve.
Sorry. Let me just check my internet connection. Am I okay now?
You're back now.
Sorry, I think my internet's a little bit flaky today for some reason. I was just going to say the second point I wish to emphasise is to shield for as long as the government tells us. The 51-page document that came out after Boris's TV appearance recently suggests that is to at least the end of June. And the third thing that I think we might discuss today is, that's all fine, but I've got a business to run, or I've got a job to go to, or I've got a living to earn in other ways, I've got kids to send to school. If this carries on beyond the end of June, what does that look like? And particularly, what does it look like for CML patients? And again, that's uncertain, but I think the time is approaching. If shielding overall is meant to continue beyond the end of June, then I think folk with CML and their families have a more trickier balance to strike between the risks and benefits of shielding versus going back to some kind of normality. So those are just my opening comments.
Thanks, Steve. And Nigel, did you have any opening comments you wanted to make before we go into the questions?
Not really, just reaffirming what Steve was saying. I think it is a difficult thing for CML patients with regard to the potential of being forced is the wrong word to go back to work, but having the choice to make about going back to work or not, and what that work actually involves. I mean, I'll talk about myself, no doubt, a little bit later, the choice I've made. But there's working in a supermarket, having people coming through past the till constantly, and there's working in an office where you are in a fairly cocooned environment, potentially with a handful of people around you. So it's a difficult thing to call.
Okay, thanks, Nigel. I think we'll get straight into the questions then, because we've had quite a lot have come through. So the first thing is around the suggestion that shielding may continue beyond the 30th of June, and that's something obviously that's suggested that the shielding is until the end of June at least. So from a CML specific perspective, Steve, how important is it that shielding certainly continues until the end of June and possibly beyond?
Yeah, that is the key question, and we could talk about that for the whole hour, couldn't we, Zach? The honest answer is beyond the end of June, it's pretty tricky. And I think between now and then, for the next 5 or 6 weeks, I think it really depends on life circumstances for individuals. It's very easy for me to say, oh, you absolutely should shield, because my kids are finished with school now. They've left home and they're at uni or working or what have you. So I don't have that dilemma. I can do a lot of my work sat here on a computer doing email, phone, even clinical work. I am doing, I'd say 90% of my consults over the telephone or through the web or whatever. So it's relatively easy for me to say you should just shield. But I think if you can, and if your work life circumstances allow you until the end of June to keep in that position, it's 6 weeks. The risk will have hopefully reduced by that time of getting this if you go out into the wider world. And I still think for 6 weeks, if you're able to, you should try and stick with it. If you're under pressure to return to work, I suspect we'll talk about schools and kids and what that might all look like. But if those pressures are in your life, then I think one has to weigh up risk and balance and decide individually whether or not you want to carry on shielding or not. But I just think if at all possible, you should stick with the program and keep shielding until the end of June, when the risk hopefully will be a lot less for all of us, but particularly those who are more vulnerable and who are shielding.
And the one thing I would just add there is that, I have shielded and I am out and about now because of my need to work, because of my personal circumstance, etc. But what is very interesting, and for those people that aren't shielding will agree with this, I'm sure, is that, it's pretty well back to normal out there, or certainly it is where I am. There's a lot of cars out, there's a lot of people about. People are generally trying to keep a little bit of distance, but if you go anywhere near a shop or a supermarket, whilst there's the superficial 2 meters to get in, when you're in there, everyone's just acting as normal, really. So I think for that reason, it's a very strong argument to keep shielding if you are able to, because the reality is out in the real world, people are just not exactly ignoring it, but they're getting on with it.
Do we have any data for CML specifically, Steve? Do we have any information as to what the effect of COVID is on CML patients?
Again, really important question. We touched on that in the last webinar that we had. Nothing's really changed. I think CML is a rare condition, and therefore accumulating a big group of patients to provide understanding of the experience of patients with CML is always going to be a challenge. And I think my honest view is I don't think we'll ever accumulate robust evidence as to whether CML patients are more at risk of COVID or not, because I just don't think the numbers will be sufficient. I think so the simple answer is no, we don't have strong evidence, and I don't see it coming anytime soon. To kind of expand on that a little bit, if you're going to start having to think about more nuanced risk-benefit balance as we face a prolonged period of shielding, I'm not seeing, I haven't seen a single patient with CML or heard of one who has had COVID. There probably is one around the country, but I've not heard from it, from my colleagues about that. I've not seen any patients locally who contracted COVID who've got CML, to my knowledge. So, and we don't see, and I think we touched on this before, we don't see lots of patients with CML who have lots of problems with viral infections generally, coughs, colds, flu. I don't detect that in my clinic, but there is some lab evidence, if you like, that CML patients don't produce such good responses when they get vaccinations, for example, immunizations, but it's sort of theoretical, that. But the simple answer to your question, Zach, is no, we don't have any newer evidence to inform whether CML patients are at greater risk or not. I throw in one more comment, but before you might come back with your next questions, which is, it's very clear some patients who have had CML, and I particularly mean bone marrow transplant recipients, which is a minority these days, but I think that's a simple thing to my mind. If you've had a bone marrow transplant for CML at any point in the past, I think even more you'd be wise to shield if at all possible. I think folk like Nigel, who've done very well on drug treatment, who've not had a transplant, are a very different kettle of fish, as it were. We can discuss that, but I just make the point about transplants, which will be, I suspect, a small number, maybe nobody on the call today, but I think that particular group needs to take more precautions.
I think I would add to that, you know, and obviously I'm not a doctor, but yeah, it makes absolute sense that you've got a shield in those circumstances. And again, this is a personal view. You know, I'm 10 years in and I'm working in a relatively safe environment because I meet with very few people. But I have to say, if I was newly diagnosed, and newly is probably 6-12 months, I hadn't achieved a major molecular response or around that level, I certainly would be shielding. Mine is 10 years of being a patient. I think if you're relatively newly diagnosed, I would be being very careful.
So I think that raises an important question, and I don't know whether, Steve, you can give us any guidance on that. I know we don't have any data, but for CML patients, are there different groups beyond those who've had a transplant that you would consider to be more at risk and that might want to prioritize shielding more than other patients?
I hope I'm scientific in my approach to life and evidence-based, at least I try to be. So if I stick to my principles, the honest answer is I don't know, and I don't think anybody does. I think Nigel's comment or observation there is fairly sensible, but could I show you evidence that people within the first 3 months of diagnosis are more at risk than those who are maybe 3 years in? No, I can't show you that evidence. So I don't know the answer, and I don't think anybody knows the answer, apart from the bone marrow transplant thing I mentioned a little bit earlier. And it's still unclear whether imatinib, you know, it increases your risk, decreases your risk, or has no effect whatsoever. So both from the disease point of view and its treatment, it's very difficult, if not impossible, to separate out different classes of stage or response in CML to say that one group is more or less at risk than another group.
Thank you. I think the things that we don't know are equally important to kind of point out. So one of the questions that we've had through is around shielding and some of the kind of things that make shielding stricter than other people, the general population, were living with during the lockdown. Things like exercise, how or if it's appropriate at all to be leaving the house for exercise, or whether people should be strictly shielding and not leaving the house at all. I mean, maybe Steve and then Nigel. You probably both have comments on this.
So, you know, this isn't a CML question. It's a sort of government policy, general shielding type question. So let me be clear. The shielding guidelines, I think, if at all possible, should be followed. That includes not going out for exercise. Now, if you said to me, it's a lovely sunny day where I am at the moment, that I just can't go outside, I can't go and walk my dog or go and get some fresh air, I would go around the twist. So I completely understand people's need for that. And personally, but this isn't a CML thing, I think it's just an observation. I think it's okay probably to go and get some exercise outside, but I'd go and do it somewhere where there's no other people. If you've got a dog, go and take it to the furthest, most isolated person you can early in the morning before anyone else is around. And alternatively, don't go for a jog through the middle of town when you're going to run past 28 people. So I think the nature and the context of where you're doing your exercise requires a bit of common sense as well. Just avoid people, go into the fresh air somewhere. I can't imagine if you go for a walk in the fields or the woods somewhere and hardly see anybody, that you're going to put yourself at great risk. And I think for your mental and physical health, exercise is pretty important.
Do you have anything to add, Nigel?
No, I think that, you know, sums it up perfectly. I was watching something on the TV the other day, and they were showing some people outside a shop in London queuing up to get some food, etc. And I just looked at the background, and the street was very busy. This was before lockdown had actually finished. There was a couple of buses going up and down the road, and there were people queuing. It's the availability of having space around you. I know that's an absolutely obvious statement, but if you've got the space or you're able to drive to somewhere there is the space, would concur with Steve. If you're going out to exercise and that's going for a walk, but you're going past a lot of people, you know, it's a much harder call to make that.
And if CML patients are leaving the house at any point, Steve, whether that's now or whether that's later, once perhaps shielding's relaxed, what strategies should they be employing to minimise their risk when they go out? Whether, I mean, obvious things that we've had questions around include gloves, masks, hand gel. I mean, are any of these things that CML patients should be thinking about?
Three sort of points or three thoughts come to mind there, really. The first is just avoid people. You know, I think the risk is if you sit next to 3-4 people on a bus with a mask on, I think personally that's more risky than if you go for a walk in the countryside with your dog, you know, in the fresh air, because there's nobody around. So I think keep it simple, just avoid people, stay your 2 or 3 meters away is observation one. Number two is about masks. We've all heard loads about masks in the media recently. We're having those discussions in our COVID meetings at the hospital at the moment. At the moment, I don't wear a mask in clinic because I think the evidence for needing to do that is thin, if not non-existent. And I don't think I want us all to be all wearing masks all the time when there's no great evidence for that. But if you have CML and you have to go out, there's not much of a downside to wearing a mask if you've got one. So I think feel free to wear a mask. And probably if I had to go and get a prescription from the chemist and I had CML, I'd probably put a mask on because there's not much downside to it. The third thing, it might just be relevant to, I saw one question related to this pop up on the screen. I had a lady last week who contacted us to say, well, at the moment, we're trying to get people to come for a blood test to the hospital, disappear as quick as possible, and then we'll phone them the next day or a week or two later with a PCR result and have a consult over the phone. So that means you've got to come out of your house, you've got to go to a hospital and have your blood taken. Some people have that at the GP. And I've had one lady last week said, you know, I just don't want to come out of the house to have any bloods done anywhere. Can I have a consult with you on the phone next week without having any bloods done? Because I'm nervous about that. And I understand that. And she happens to be pretty stable. So I think at the moment that's probably okay. But I think if you have to go and get your bloods done, a medical necessity, or get your prescription, try and work out yourself, which is the lower risk. You know, are you going to a GP's practice where if you walk in the waiting room, there's 20 people, I'd walk out again and I'd go and get it at the hospital. Likewise, if you're in a hospital waiting room with 20 people and it's not very well organized, bail out and go to your GP. So it depends on those individual circumstances. But I think the key thing is just common sense. Just keep away from people as much as you can. Wear a mask if you feel that would be helpful to you, although I'm not sure it's critical. And probably you're going to have to go and get your blood test at some point. But maybe if you're very stable, you could question whether you need one this month or could it wait till July or August and have some bloods later.
That's good. That's interesting because that was going to be my next question.
No,
that's that's good. So one of the questions that's come up particularly recently is obviously in relation to Boris's announcements and schools, for example, being encouraged to go back for some year groups. How about CML patients who have children? Should their children be going back to school, given if the patient themselves is shielding? What are your thoughts on that, Steve?
I think this is maybe the hardest question, and you know, I'm again, this isn't really a sort of CML related question. It's a dealing with unknown risks when you yourself, you know, unknown risks about returning to school, the transmission of virus in an increasing population that would appear in schools, etc. But also the unknown risk of whether that could be brought home to you and presents you personally with a risk. And, you know, I really struggle with this one, and we're all watching the news at the moment and scratching our heads. A lot of my mates are teachers, and we've had quite a few debates about, on Zoom, I would hasten to add, about whether this is a smart thing to do or not. And I wonder whether, you know, going back in June or July is useful when we could just wait a few more months and all go back in September with a bit more time to organise and hopefully a bit lower risk of viral transmission. But that's not a decision for me or us to make. I guess we're going to be advised by the government in that regard. So let me pin it down. If I had young kids and I had CML, and I was being advised to send my kids to school on the 1st of June, would I do that? I think I would. I think I would, because school's important, and I really worry about the generation or the cohort of kids who are missing out at the moment on their education. And I think the risk of them contracting it is relatively small. And the risk of them bringing it home and giving it to you and you being poorly is relatively small. I'd qualify that a little bit with an age comment. So if you're listening to this and you're a CML patient who is 73, i.e. at risk because of your age, not maybe classified by CML, and you're a grandma or a granddad who normally takes your grandchildren to school, I think I'd avoid doing that. But that's an age thing and not a CML thing. So that's my personal take on it, Zach. I think take or leave that as you wish, but I think it's a particularly tricky situation for people.
Thanks, David. Go on, Nigel.
Yeah, and I was going to say, I think as a patient, and I probably wouldn't, I have to say. I think if we were in a position where we could afford not to, you know, if my wife was able to be off or I was able to be off, and I'd got young children, I think I personally probably wouldn't. I think I would look at it on the basis of 1st of June, middle of July, 6 weeks. I think that's really, from my own point of view, swayed by the fact my wife, when I was first diagnosed, worked as a nursery nurse, you know, preschool, and she was constantly ill. You know, she would pick up all sorts of things from the children, bring them home, not particularly give it to me, but she was constantly ill. And she left the job as soon as I was diagnosed because we didn't want the risk of her bringing something home. So I sort of look at it and think, well, I look at the illness she had. There's no knowledge whether that can be passed from the children to the parent and then on to the patient. And I think in that sense, I would personally shield in that situation. That's my personal view. And that's from experience from my wife and knowing how regularly she used to be ill, picking things up from young children.
Completely fair point of view. So you've got contrasting views there, which is often the way. I guess the other part of this is to do with work, of course. You know, if you're being expected to go back to work on the 1st of June, then you need maybe with a higher priority to get your kids back into school. But I think going back to the original basis of this, if you are shielding, I think your employer should be sensitive to that. I think they have an obligation to be, and you can obviously let them know that you can't get work because you're shielding, which removes perhaps the pressure to have the children go to school so that you can go to work. But that's a slightly different point.
So I think there's two really interesting questions in relation to employment, and you've kind of alluded to the answer to the first one there, Steve. Just Charlotte, could you comment from a leukemia care perspective as to what people should do if they're struggling with their employers asking them to go back to work when they are in the shielding period as patients?
Yes, so if you as a shielded person are being asked to go back to work, the government guidance is that this period doesn't end until the 30th of June. So you should be supported to at least complete that first period. And if you're having trouble with that, if you haven't got a letter and the employer's questioning that, or even with the letter, they're still not quite understanding your situation, please get in touch. We can help you with that. If there are others in your household that are being asked to go back to work or school, and you, the shielded person, are worried about that sort of breaking down the shielding as such, the advice from the government is to, as I mentioned, social distance yourself within the household. Whether or not that's feasible is something you'll have to think about for yourself. And if you are concerned about maintaining that social distancing, please get in touch. We can sort of talk you through it and see if we can support you to to have that conversation with your employer or with the school and see if we can support you somehow. Does that answer the question?
I must say you're all making my life very easy because you're all answering the next question as well. I mean, Steve, do you have
Great.
a clinical perspective on people who live with CML patients who are shielding and how appropriate it is for them to be now going back to work?
Not anything that would add to what Charlotte's already very eloquently stated. So, yeah, I don't think I've got anything to add beyond what she said.
And Nigel, I mean, you've mentioned that you are you have work and you've had to go back to work for a period. I mean, from your perspective, do you have any comments that you'd like to add?
No, I mean, my circumstance is that I'm 10 years diagnosed. I have very, very low PCR, and I rarely pick up any illnesses. More so, when I say rarely, I mean, you know, than the average general public. So because I'm an employer and it is my business, I'm a little bit boxed into a corner. Would I have gone back now? No, I think I would have rather have gone back on the 1st of June when every other business went back, or more businesses went back, but we were sort of boxed into a corner. So, you know, we had to, but I'm in a fortunate situation that I work in an office with only a limited number of people, and I don't see that many people externally, and when I do see them externally, I generally have the ability to socially distance with them. So in that sense, I am still following, you know, the government guidelines and trying to give myself as much protection. The one question I've just back to Charlotte for a second. You talked about shielding, etc. If somebody is shielding, and I don't know the answer to this, are they then off work unpaid, or are they furloughed? I assume they're not furloughed, because that obviously has a major effect on the income that they would earn.
So they can be furloughed, and so the first thing we've been trying to have a conversation with employers about is whether someone, not employers, sorry, patients to have with their employers, is whether someone can work from home as the first step, because quite a few of people, most people have a job that can in some part be done at home, and then furloughing is sort of the next option after that. And I have to say, I think, although you get only 80% of your pay, I think a lot of the people we've spoken to have had that topped up, or have said they are able to cope on that, and versus unpaid, that's a good outcome for them. But obviously it may not be for everyone, but working within the circumstances that we've got, I guess. Yeah,
I was going to say, because as an employer, the furlough scheme costs the business nothing. So there is no reason why an employer shouldn't furlough somebody. They would certainly be better off than they would be if they're on SSP or something like that.
Yeah, and that's what we're encouraging, absolutely.
So we've had some really interesting questions come in that perhaps Steve can answer in terms of other situations and CML that may add to your risk. So one being CML during pregnancy, and perhaps you could comment about that and whether we have any information.
I'm going to sound like a bit of a broken record, Zach, I'm afraid. So I don't know, is the honest answer. Do we have any information? No. Do I have a view about whether if you have CML and are pregnant, you're at greater risk? My sense is, and this is very unscientific, but I think, you know, there obviously can be problems in early pregnancy regardless of COVID and CML. Usually, fortunately not, but it's a time of increased stress on your body. And I think if you've got CML and there's a risk of virus, my inclination intuitively is just to be a little bit more cautious about shielding if you are in that situation. Obviously quite a rare situation to have CML and be pregnant, but certainly it happens. And I think I would just be that bit more cautious there, but I can't give you chapter and verse in terms of evidence. That's just a clinical intuition.
And we've also had a question in relation to dasatinib and pleural effusion, and obviously the potential impact of COVID on the lungs. Have you got any comments that you can make in relation to that, Steve?
That's a good question. Again, no evidence, but I've done a lot of work with dasatinib over the years in trials and what have you. The mechanism of the causation of the pleural effusion on dasatinib is not really well understood, number one. Number two, pleural effusion as a feature of COVID-19 is not common. It tends to be more of a pneumonitis, if you like, an inflammation of the sponges of your lungs rather than something that causes fluid to accumulate around the outside. Number three, I can't think of a good biological reason why, if you're on dasatinib, which may be associated with pleural effusion, that would necessarily make your susceptibility or your outcome from COVID-19 different. So I wouldn't be unduly concerned if you are on this call and are on dasatinib. I certainly wouldn't stop it or switch to another medication just because of a COVID-19 risk. And again, I've not heard of any patients on dasatinib who've had COVID, and therefore we can't really tell whether that's all correct or not. But I don't think it presents a greater risk than the other TKIs would be my position, I think.
Thank you. And we've also had quite a few questions in relation to vaccines, and specifically vaccines that are in development and whether they would be applicable or even prioritised for CML patients. I know we talked about in the last CML webinar, but perhaps you could either repeat what you said before, or if the situation has changed. Again, what's your view, Steve?
A few thoughts there. Number one, I think protocols for vaccine development at the moment would probably exclude patients with significant underlying medical conditions, and having CML, I think, would be one of those. And therefore, it's unlikely you would be accepted on a vaccine trial. The purpose of all trials of new human medications is to ensure safety first and foremost, and they would probably not take on patients with CML just to be as risk averse as possible, number one. Number two, and again, this is an observation on vaccinology rather than CML, I suspect by the time this vaccine story comes to fruition, we may well not be in the same position at all with COVID. It may be a much lesser problem. And I commonly hear expectations of about a year or so to see a vaccine through into clinical practice, and I think that's realistic. It takes quite a while to develop a vaccine. It's not a quick thing unless you have a lot of luck. So, and we may, be, I wouldn't say we'd be COVID-free next year, but I think we might be in a very different position. We might have accumulated large amounts of herd immunity in the population. The virus might have changed to become less virulent. There might be a new one around for which the vaccine doesn't work. So I think don't hang your hat on waiting for a vaccine to fix our problems with immunity. And the third thing is, I think you alluded to prioritization. Would patients with a variety of conditions, including CML, be prioritized? I could see a good case for that, and there's precedent for it. Things like pneumovax and pneumonia vaccine are often given with priority to patients with cancer or more vulnerable patients. Even the flu vaccine is often prioritized towards patients with greater vulnerability. So I could foresee in a year or so, if this vaccine works, that patients with CML might well be offered it with some priority, but that's a guess for the future. I don't think we really know, Zach.
Thanks. And then another question that's come in, you mentioned earlier, Stephen, it'd be interesting to get both your thoughts and Nigel's on this. You mentioned telephone consultations, and that you're doing most of your consultations by that method. Yeah. Have you got any tips for people to make sure that they get the most out of a telephone conversation instead of an in-person conversation?
I'm going to let Nigel go first, because I've been doing lots of talking. So Nigel, I don't know if you're having a telephone consult, and if so, what's been your experience and what might be your tips for doctors to do it better?
I haven't actually had one. My last clinical appointment was about 3 or 4 days before lockdown happened. Therefore, my next one is about another 3 weeks away, so I've not experienced it. From a personal point of view, because I'm relatively fit and well, I've often thought for a long time I don't actually need to go into hospital and waste the doctor's time, to be quite honest, although I don't actually see a doctor anymore. I see a pharmacist, and I have done for probably the last 2 or 3 years. I think it's just being prepared, and I think arguably having the appointment at home gives somebody more ability to be prepared, to write questions down, to not forget them because they're dashing out of the house, etc. So I see no problem with it. I think particularly if you're fit and well, I think some people do like to see a doctor face to face, understandably, and feel less comfortable talking on the phone. Some people just don't particularly like that. They like that personal interaction. But I have nothing, as I say, other than making notes about what you want to discuss. There's nothing really from my point of view. And I think it's a shame in some ways that this doesn't maybe go a bit more this way, and maybe we will from this for patients that are long-standing or fit and well.
So a couple of thoughts from me. First is, I think, strangely, there are going to be some good things that come out of this horrible virus experience. Maybe we all know our neighbors a bit more. Maybe we don't pollute the planet a bit more. Maybe there's less traffic. All of these things that, you know, have been forced upon us may end up being good things. I don't think we're ever going to do our clinics the same again. We've been pushed into doing this phone conversation thing, and I don't think we'll go back to seeing, you know, everybody in the clinic in the usual way, perhaps for the reasons that Nigel's just mentioned. So that's observation one. I think it's changed our practice for good. Observation two might be, if you're on this webinar and you've not been offered a phone consultation, I think you should ask why not, because I think it does reduce risk. It's actually lots more convenient for people. I have a chap who lives on Holy Island up on the Northumbrian coast, and to get to clinic, he has to time his run with the tide. So he's delighted that I've spoken to him on the phone, because he can just look out over the sea and not have to worry about getting home and being stranded. So, you know, that's a trite observation, but there's lots of people who are saying, I really like this. And we block a period of time on a Thursday afternoon. We have 3 hours where it's a bit like an Amazon drop. We say, you know, I'm sorry, I can't tell you I'll call you exactly at 3:15, but between those 3 hours, you'll get a call, and it generally works pretty well. And I think the third thing is just about, maybe about the technology and about human interaction. I mean, I rely quite a lot on just looking somebody in the eye and or seeing them walk in to kind of work out whether someone's okay or not, you know, whether they look poorly or whether they look a bit sadder than normal and there's something on their mind. And on a phone call, I'm finding I've lost that a little bit, and I don't like that. It's harder to connect with people on the phone. We are trying, and I've not yet used it, we're trying in our place to pilot a dedicated video thing like this for consultations, and some of you may have participated in that. We're generally not using Zoom, although I think maybe we should more. So if you can, I think connect with your doctor at least with a video link, because we're all human and we all like to see each other and see faces and connect in that way. But we have some pretty good technology these days. So I think it's going to be how we do a lot of our work and consultations in the future. And we've been forced into working out the logistics of that, the coordination of it. You know, you come into clinic, you pick a bag of pills up, you have your blood, you run out, and then you get a phone call. I mean, that sounds simplistic to deliver, but actually there's quite a lot of pre-prescribing around that, and a lot of organisation to make sure we can all do it. And we've upped our game because we've had to. And I think a lot of hospitals, if not all hospitals, will be doing the same thing. So maybe some good will come out of it.
Question on that, which you've just raised, and it is something that I was going to ask, was exactly that. You talk about going in and having your blood tests. So you're actually issuing prescription at the same time on the basis that the blood tests are okay.
Yeah, which is a bit of an assumption, but for most people it works. So we do this on a Wednesday morning. So we have a power, we've got a big Excel spreadsheet of all the patients coming the following week, which we look at on a Thursday and Friday. We'll sit down and do all the chemo prescribing, all the TKI prescribing on a Friday typically. The pharmacy will process that into bags full of pills on Monday, Tuesday, and then in the clinic area on a Wednesday, we have a table with a big line of bags on, and a big line of people waiting for blood test. They come in, have the blood, give them the pills. We then check the PCR when it comes through in a week or two, schedule them for a phone conversation, and by and large say, carry on taking the same pills. The risk there is you're giving someone a packet of pills maybe when you're going to change the treatment, but that doesn't happen very often, and you can often anticipate that from the blood results. So, you know, we see someone in the clinic, we'd send them off to the pharmacy, they'd have to wait for an hour or two there, get the pills, go home. Some patients would have home delivery, but that's kind of fallen to pieces a little bit because of manpower constraints or limitations. So again, we still do some of that home delivery and home bloods for some patients, but it's a minority because there's not been the people out in the field to do it recently. So it's very different to what we were doing 6 months ago.
I think, again, two things I'd add there, because certainly I'm at QE in Birmingham, and yes, the waiting room's always busy when you're waiting for your consultation, but also when you go across the pharmacy, that's very busy when you're walking in. And it did cross my mind about what will happen about, you know, that social mixing, but you already have the tablets waiting, which is interesting.
Yeah, but that took weeks to thrash out. You know, I tried really hard to make that all work, and then for the first 4 weeks, you know, someone's pills wouldn't be there, and someone would forget this, and you know, it was quite a challenge to actually just make it work, even though it's like Amazon, it's moving packets of things around to make sure they're in the right place at the right time.
The other question is, if you have bloods done at a GP, more for everyone else listening that I asked this question, but what's the timescales the bloods have to be received at the labs, basically? Because I think there's a worry that the bloods would be done, they're hanging around, they get to the labs and they've spoiled. Whereas if you haven't them done at the hospital, there's the confidence they're being done at the hospital. So it's more just if you can give idea on timings.
I think, I mean, the blood count and the biochem samples, they'll last a couple of days actually. The PCR is more critical. It kind of goes off quite swiftly, the RNA and the PCR, which is... it was probably
that I meant, sorry.
You know, no, understood. So 48 hours is pushing it, 24 hours is ideal, but normally GP practices are pretty well set up for that. So, you know, if you have a blood sample taken in the morning, it'll get in a van into the hospital in the afternoon and be analysed, processed pretty quickly. So it would be unusual in most places to have a sample languishing for 48 hours. As a general observation, I personally would never go and have a blood test on a Friday because you're asking for trouble there with a weekend problem. So if you're going to get your bloods, always go on a Monday, Tuesday, or Wednesday would be my simplistic observation about how the health service works.
And again, from a simplistic point of view, are you better to have a full blood count done at local surgery and a PCR done at hospital, which then takes you to hospital once every 6 months, or does it not matter, do you think?
Nice idea, but I think logistically it would probably fall to pieces. I think you're probably best having a set of bloods, which is usually 3 tubes, you know, biochem, a blood count, and a PCR tube, all done at the same time. Quite often it does fall to bits at the GP surgery because you may well have someone who's taking a blood sample from you who's never heard of a PCR. So, you know, it's a minority of our patients who have them done at the GP. It's usually at the hospital or a surrounding hospital because that clinic is used to what a PCR sample looks like and make sure it gets sent to the right place in a timely way. But, you know, again, an observation here is sort of taking ownership and making sure that people do the right thing for you. So, again, if I had CML and went to my GP for the bloods, I'd sort of say, have you taken a PCR? And can I just check the form is right and it's going to the right place? Because I'd be quite a stroppy patient, I think. But just, you know, make sure when someone's sticking a needle in your arm, just say to them, have you got a PCR sample as well? There's no harm in doing that. No one will mind. And it avoids you having a set of bloods which is incomplete.
Thanks,
Steve. So I think just one really obvious question that we've already answered before, but just so we repeat the message, the shielding guidance runs until the end of June. What should people be doing until the end of June, Steve?
Simplistically, I think stick with the program. I think it's not 6 months, it's 6 weeks. I know things are changing quickly. We're all watching the news. It's becoming more difficult to balance up the risks versus the demands upon yourself and your family for getting on with life. But if you can, manage your circumstances such that it will allow you to, you should shield, I think, for the next 6 weeks. After that period of time, I think it depends on how long you're being asked to shield for, what the government comes up with. But it's not just patients with CML. There are thousands, if not hundreds of thousands of people who've been hoovered up in this very perhaps overly cautious basket of people who need to shield, where the government's going to have to think about more nuanced risk assessment for those people. And that was mentioned in that document I touched on before. You know, can we be a bit more precise about whether people do need to shield or not? And it could be at that point that for patients with CML particularly, we may come down to some more refined, you know, comments or categories about who can and should shield. I could foresee a situation at some point where people who've had a bone marrow transplant for acute lymphoblastic leukemia, who are on steroids, who are over 50, for example, might be required to shield, but patients like Nigel, who are fine, 10 years out, doing absolutely fine, might not be. You know, that's not what it says at the moment, so I'm not advocating that. Stick with it for the time being, but maybe at the end of June or July, there may be some refinements as to the risk and benefit profile of who should shield and what the risk to them is of unshielding.
Thanks, Steve. And certainly we can look to provide more information and another opportunity for discussion as and when the guidance is updated and we know what will be happening beyond that end of June period at the moment. Charlotte, I know you have a comment to make in terms of what people should be doing if they have any questions that weren't answered in the webinar or want to get in touch afterwards.
Oh, I've shut my slides. That's annoying. Okay, I will just talk from memory. So yes, the general message is please do get in touch if you need any support. So from a COVID perspective, we can help you work out all sorts of things. So if you haven't got a letter, should you be shielding? If you're not sure, we can talk you through the guidance. If you want assistance talking to employers or schools or anything like that, as I said before, please do get in touch. We can talk you through that. And I know finances is a big thing for people at this point in time, especially if you're trying to shield and not returning to work. You might be concerned about how you're going to support yourself. We have a welfare benefits advisor who will be able to talk you through your options at the moment. And we've already mentioned the furlough scheme, but if that doesn't apply to you, there are other things we can look at to support you. And then in terms of more generally, I think it's just important to say that we're still here as Leukaemia Care. We're still providing as many services as we can. So there's, for example, we've got our webinars when we're putting out regular information in the form of blogs and magazines and newsletters. So if you're not signed up to our communications, I'd urge you to do so, and you can do so on the website. And then in terms of if you're looking for more sort of emotional support or just sort of general chances to catch up with other patients at the moment, because I know we're all quite isolated, people who are shielding probably more so. We are running virtual versions of our support groups, which you can find listed on our website. We are still running our buddy scheme. We've still got our online forums, and we've also Facebook groups like Nigel runs as well. So there are still lots of options out there if you want to connect with patients. We've adapted them to the new online world where possible. And I will very quickly type our email address into the chat box in case anybody needs any more information.
I'll just interject here 1 second, actually talk about the virtual meetings. There is a virtual meeting this Saturday morning at 10:30, which is the Birmingham meeting, which has now been merged with the Manchester meeting. And that is going to be chaired by Manoj Raghavan from the QE, who heads up CML there, and also Nick Duncan, who is my specialist pharmacist at the QE as well. Both very good, well worth a join in. And that's, I say, Saturday morning, a little bit of a plug for it, but that'll be more a Q&A, everyone out there asking questions, etc. Sorry, Zach, I can see you smiling in the background. Were you going to raise that?
My job's really easy. Everybody says everything I need to say. So, But no, I was just going to say, yes, obviously Nigel's helping us with those virtual support groups for CML this weekend. So I was going to say thank you to Nigel for helping with that, and also thank you to Nigel, Steve and Charlotte for joining us for the webinar. We've had lots of positive comments on here. So thank you very much for your time. I hope everybody listening found that useful. And as I said, we'll look to provide more information as and when the situation changes. But you've heard the advice, you know what you should be doing until the end of June. So thank you everyone for joining us.
Could I just finish on a positive note? Two things really. One is I think we really are past the worst of this at the moment. You know, we had a really dark few weeks in the hospital when it all felt very odd. It actually became very quiet on our cancer unit because people were just staying away, and we were all watching fearfully as to the number of COVID patients coming through. We are definitely past the worst of that. So I think that's the first thing to say, is this is not doom and gloom, this situation. Clearly we have to be cautious, but I can really see at the coalface, as it were, that it's improving, number one. Number two, overall, I don't think patients with CML are at particular risk, and I'm not seeing lots of people contracting COVID and having poor outcomes with it. So I know you'll all have lots of concerns. We've had lots of debates about what to do in various situations. We're taking a cautious approach by shielding, but I don't think you need to be too worried from both of those reasons. I don't think you're a particularly great risk, and I think the worst is probably over.
Okay, thanks. A nice note to end it on, Steve.
Okay.
Thank you everyone for your time. That was greatly appreciated. Thanks. And I hope to see you all again soon.
Take care.
Thank you.
Bye-bye.